All right, this is chapter 45, and we are going to be looking at the diagnostic assessment of the gastrointestinal system. This chapter is going to start for us on page 1118, and we will finish out the chapter. For our GI diagnostic assessments, we will usually start with our laboratory studies. For our serum tests, we will do a CBC because this can help diagnose anemia and infection. GI bleeding is the most common cause of anemia, and it can be caused by GI cancers, peptic ulcer disease, diverticulitis, and inflammatory bowel disease. We will check a prothrombin time. This is a PT, and this is going to measure the rate at which prothrombin is converted to thrombin. This can evaluate levels of clotting factors. Hepatocellular liver disease leads to prolonged PT due to impaired formation of clotting proteins. Those with an increased PT means it is taking longer than normal for blood to clot, therefore these patients are at risk for bleeding. We are going to check electrolyte levels. Electrolytes may be altered. For example, calcium is absorbed in the GI tract, and it can be measured to check to see if there's any malabsorption going on in the GI tract. A patient with excessive vomiting and diarrhea may have low sodium and potassium levels. For enzymes, we have an AST and an ALT. These are usually abbreviated like this, and you will see these. They are two enzymes found in the liver, and they're elevated with most liver disorders. So if you get a patient and they're here, they have cirrhosis of the liver, or they have any kind of hepatitis, you're going to look at that AST and ALT to see what's going on. The highest levels are with disorders that can cause necrosis, such as hepatitis and cirrhosis. We have amylase. This is an enzyme that breaks down carbohydrates, and it is produced in the pancreas and salivary glands. We have lipase. This is a pancreatic enzyme that breaks down fats. Elevations in amylase and lipase can indicate acute pancreatitis. However, they are not elevated in chronic pancreatitis. We'll start to see some compensation there. We have our bilirubin. This is the primary pigment in bile. It is normally conjugated or bonded and excreted in the liver. Elevated levels indicate impaired excretion in liver or biliary tract functioning. Ammonia. This is measured to evaluate liver function. This is normally used to rebuild amino acids or converted to urea for excretion. High levels indicate hepatocellular injury and conditions. Usually, this occurs with cirrhosis, hepatitis, and hepatic encephalopathy. And we will actually cover these conditions a little bit more in chapter 50 and talk about the elevated ammonia levels that are going to go with those diseases. We also have our cancer antigen and carcinoembryonic antigens. These are going to be used to evaluate cancer treatment efficacy or GI cancer recurrence. However, other GI conditions can cause these levels to be elevated. If you guys will take a look at table 45.2, it is on page 1120. It is going to show each lab value and what GI conditions that they can indicate. After our serum test, we will be looking at the urine. In our urine amylase levels are elevated in acute pancreatitis. Urobilinogen is a type of bilirubin converted in the intestines and excreted in the urine. High levels indicate liver or biliary obstruction before jaundice appears. We have our stool tests. The American Cancer Society states that regular screening of stool can detect colorectal cancer early, and it is recommended every 3 years. So that's saying that the stool samples and a stool exam is recommended every 3 years, and it's covered by most insurance. All positive results are followed by a colonoscopy. If a patient has malabsorption, fat is excreted in the stool, and it should actually be seen on those screenings. For our imaging assessments, this is usually going to be a big one with our GI disorders. So our x-rays, these are going to identify masses, tumors, strictures, obstructions, and ileus. Usually the first imaging is ordered here to diagnose GI problems. No patient prep is required except the removal of any jewelry or belts. When patients have severe abdominal pain or a suspected bowel perforation, an acute abdomen series may be ordered. And that acute abdomen series is a series of x-rays, and it's going to include a chest x-ray, a supine abdomen, and an upright abdomen. So these are different positions that the patient may be in. Next, we have our CT scans. These are going to detect tissue densities and abnormalities in the abdomen, liver, pancreas, spleen, and biliary tract. Verify your patient's allergies. If contrast is ordered, the patient should be NPO for at least 4 hours before the scan, and make sure your patient does not have a contrast allergy. A patient IV is preferable for a 20 gauge or larger in the AC for contrast. This is actually one of the reasons that the emergency department often places IVs in AC. It's a good, reliable, large vein for CT scan contrast. For patient education, contrast can cause a warm, flushed feeling and a metallic taste. Have the patient lie still and hold their breath when they are instructed. Claustrophobic patients may need a sedative. Without contrast, scans take 10 minutes, and with contrast, the scans can take about 30 minutes. For our MRI, detailed pictures of the abdomen and abdominal organs are going to be taken here. Ask the patient about medical implants due to the magnet that is always on during an MRI. We've talked about it before, but anytime you have a patient who's going to go to an MRI, they're going to have screening questions before they go, just to verify it's even safe for them to be in the room with this magnet. And then our American Cancer Society screening guidelines for imaging options in adults who are older than 45 to detect colorectal cancer. We have flexible sigmoidoscopies. We get these every 5 years. We have a CT colonography. This is a virtual colonoscopy. It's recommended every 5 years. And then we have our colonoscopy, which is what you're probably familiar with. It's recommended every 10 years. Colon cancer in a patient younger than 40 is uncommon, so it's recommended for low-risk patients once they turn 45 to begin having a colonoscopy every 10 years. If they do have a family history, if they're starting to have signs or symptoms, if there's something questionable on an imaging scan, they may want to do these colonoscopies more frequently. Your video here if you just want to take a look at these images. But the picture on the left is an abdominal x-ray that shows a mass on the right side. You guys can see where the arrows are pointing for that. The top right picture is an abdominal CT scan with and without contrast. And then the bottom right picture is an abdominal MRI that shows more detailed pictures of the abdominal organs. And you guys can compare that CT scan to that MRI, and you might see how we used MRIs for a more advanced look here. So information regarding the procedures that are listed on this page are in your textbook on pages 1122 through 1126. You do not have to know every single in and out of each one of these. You will obviously learn more about these in your time as a nurse. But what you do need to know is you need to be able to recognize what a procedure consists of as far as what exactly are we doing here. For example, for an EGD, hey, I see EGD, I know that we are going to be placing a scope down the throat to look at someone's upper GI tract. Other than that, you do need to know, hey, this is what I'm going to do pre-op, and this is what I'm going to look at post-op for any kind of complications. We are going to discuss EGDs and colonoscopies on the following slides. So during an EGD, if a GI bleed is found, the healthcare provider can place clips, thermocoagulation, injection therapy, or topical hemostatic agents to address the bleeding. If the patient has an esophageal stricture, this is the narrowing of the esophageal opening, it can actually be dilated during the EGD. Sometimes you will have patients who come in, they're complaining of difficulty swallowing, and they may need to just have their esophagus stretched, and this is determined by doing an EGD, and this can actually be done more than once in the patient's lifetime. For patient education, we are going to avoid anticoagulants, aspirin, and other NSAIDs for several days to a week before the EGD because these are going to increase the risk for bleeding during the procedure. The patient will need to be NPO for 6 to 8 hours before the procedure. They need to remove dentures, explain the procedure, swallowing may be difficult after the procedure, and the patient will need to have someone drive them home. They are not able to drive for 12 to 18 hours due to the sedation that they get. It is also common for them to have a hoarse voice or a sore throat, and it may last for a few days because we are sticking a scope down their throat. The moderate sedation, like fentanyl or propofol, may depress the rate and depth of respirations during this procedure. As the nurse, we are going to monitor oxygen and ventilation and respirations. If respirations are less than 10 or their exhaled CO2 is below 20%, you can actually sternal rub the patient to stimulate deeper and faster respirations. Another thing we want to look at as far as post-op is the patient needs to be NPO until their gag reflex returns, otherwise they are at risk for aspiration. So this is an image of what an EGD looks like. I know at the hospital here in Southwell, the physician usually puts the scope in the client, and they actually have a large screen, kind of like a television, to look at that helps guide the scope rather than looking directly into the scope like in this picture here. Moving on to colonoscopies. So colonoscopies can be used to identify polyps, take biopsies, and identify and treat lower GI bleeding. Those at a higher risk for cancer or have had polyps removed should be screened more often according to their primary care provider. For our nursing interventions for patient prep, explain the procedure, educate to avoid anticoagulants, aspirin, and antiplatelets for several days before the procedure. The patient will be NPO the day of and clear liquids the day before. They will also have a bowel prep the night before and will be instructed to avoid red, orange, or purple drinks and gelatin. The reason is because these may look like blood in the lower GI tract and it can cause some false concerns or make it difficult to visualize the lower GI tract. Failure to adequately prep the bowel can lead to decreased visualization or an unsuccessful colonoscopy. I have definitely seen a patient who got there, they were sedated, we had the scope inside of them, and the physician actually had to just cancel the entire procedure because we were looking at the screen and you could not visualize anything at all because the patient had not properly done their prep. So always make sure you're educating on a proper prep. When the patient has a bowel movement before the prep, it should be clear. It should not have big flakes in it. It should be straight, clear, no solid consistency whatsoever in their stool right before they have the procedure. For positioning, we want the client to be on their left side with their knees drawn up. For our monitoring during the procedure, respirations and oxygen saturation is something we're really going to be looking at here. Respirations less than 10 or a CO2 less than 20% require a sternal rub to encourage the patient to have those deeper, faster respirations. For monitoring after the procedure, vitals should be done every 15 minutes until the patient is stable. The patient will be NPO with side rails up until they are fully alert. And we are going to assess for signs and symptoms of complications such as bowel perforation or hemorrhage. Here you're going to be looking at the abdomen. Is the abdomen swollen? Are vital signs starting to change? Things of that nature. And then teaching after the procedure, we are going to have the patient lie on their left side to promote flatus, fullness, cramping, and passing flatus is normal. If polyps were removed, a small amount of blood in the first stool is also normal, but the patient does need to report excessive bleeding or severe pain immediately. Box 45.2 on page 1125 has directions for the care of a patient after a colonoscopy. Image of a colonoscopy procedure. Once again, usually providers will insert the scope and they have a large TV-like screen to guide them and visualize the area rather than directly looking into the scope. But here you'll see the patient is turned on their side and there is a scope that goes into their rectum, and we are going to be looking at the lower GI tract here. Let's go ahead and do some audience response system questions. I'm going to give you 3 multiple choice questions and we will review the answers and rationales together. Take a moment to read the question and review your answer choices. You can pause your video here so you have time to answer, and on the next slide we will discuss the answer and the rationale. The answer to this question is D, as in Delta. The reason that we would want to question the patient taking any kind of NSAID is because large amounts of NSAIDs, such as ibuprofen, can predispose the client to peptic ulcer disease and GI bleeding. Go ahead and take a moment to read the question and review your answer choices. You can pause your video here so you can have a little bit more time, and we are going to discuss the answer and rationales on the next slide. So the answer here is going to be A, as in alpha. So evidence indicates that the client's report of passing flatus is a favorable indicator of whether peristaltic movement is returning after surgery. Therefore, we're going to ask this question as a priority. Anytime you have a patient who goes to surgery and they come back, one of the first things you're going to be looking for is you're listening to bowel sounds for that peristalsis. You want to see if they're passing any kind of flatus, and you're going to wait to see that bowel movement. Usually it may take a day or two just because the person's insides are still waking back up from that sedation that they had. So this is something that we are going to be listening for and asking about. Go ahead and take a moment to read this question and review your answer choices. You can pause your video here if you need more time. We will be reviewing the answer and the rationale on the next slide. The answer to this question is B, as in Bravo. So the older client should be monitored closely for adverse effects of all medications, even those administered in normal doses, because toxic levels can develop rapidly. Remember, your patients who are a little bit older, due to age-related changes with their metabolic system, it may take them longer to metabolize medications that you give them. So this is something that you'll monitor for.